I'm Ross Camidge. I'm the Director of Thoracic Oncology at the University of Colorado. Thymoma is a rare thoracic malignancy, and there are different subtypes. So technically, without getting into the pathological weeds, there's thymoma types A, B, and C. There are subtypes of each of those. Thymoma type C is really also called thymic carcinoma. So if you see a squamous cancer with just a lesion in the middle of the chest in the mediastinum, that's probably a thymic cancer. Thymic carcinoma, that squamous one, tends to behave a little differently, but you'll tend to see that most of the data in terms of chemotherapy lumps these things together, and that's just a reflection of the rarity of this disease. Often you'll find that the case series extend over many years, and that also means they tend to use relatively old chemotherapies. So the official answer is, if you have any kind of thymic malignancy, you really need a multidisciplinary approach. It's the kind of cancer that breaks all of the rules. Even stage 4 cancers can be resected, and there's a lot of debulking that goes on. So sometimes we bring all of these patients through our multidisciplinary team, and we're asking ourselves, are we going to start with cytotoxic therapy as a lead-in to either going to surgery or to radiation, or is the disease too widespread and we're just going to use the cytotoxic therapy to maintain control? The other thing to bear in mind, particularly for thymomas in the type A and type B, is sometimes these can move very slowly. And so if you're uncertain about the tempo of the disease, the speed at which it's changing, you may wish to keep an eye on it just to see whether maybe you could observe. Now, if you're going to use cytotoxic therapy, most of the studies will suggest a regime which is called CAP or PAC, depending on how you write it, which is cyclophosphamide, adriamycin, and cisplatin. Honestly, that's a relatively old regime, and I think it's there and it has the most data because it takes a long time to build up these case series. I personally don't use it. It can be fairly toxic. You have to worry about the cumulative dose of the anthracycline. And actually what I tend to use is plain old carboplatin and paclitaxel. One of the unique things, particularly about thymic carcinoma, that type C thymoma, is a subset of them, and you won't find this in any of the literature, but a subset of them are exquisitely sensitive to taxanes. And so if you have an incredibly dramatic response, and then you stop your carboplatin and paclitaxel after 3 cycles, and then 6 weeks later or 3 months later, it's growing back, think outside the box. Just occasionally, you can re-challenge with a taxane, like weekly paclitaxel or docetaxel. And it's amazing. It's almost like a TKI response in some people. Not everybody, but if you have that really dramatic response, just think about that. Is that the subset of thymic carcinoma, which is exquisitely sensitive to taxanes? And again, you may not find that in the literature. If these things don't work, there's a grab bag of other cytotoxics that you can try. You can find them listed in the NCCN. There's platinum etoposide. There's that CAP regime that we talked about. There's pemetrexed. I think one would tend to use that for the type A and B thymomas rather than a squamous type C, although the data is not really there. And then there's other things. People have used sunitinib. And actually, I've had some very good responses with sunitinib in some people. You tend to have to give it intermittently. But your job is to try and control this disease. You can always bring the surgeons back into the forefront. Can they re-resect when you've run out of other options? If you just have a drop met somewhere, these tends to land in the pericardium or the pleural space. Can you re-resect? And it's about keeping these patients going long term.